A very good evening and a warm welcome to all the doctors present here. I am Debolina from Clonet. Team Clonet is very proud to be a part of this webinar as a digital partner. As you all know, Clonet is India's largest live digital CME and doctors generated medical content platform. So with all of you now, I would like to share a short glimpse of Clonet. Thank you so much all for your patience. You can always find us on Google, which is www.clonate.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. You can use our Telemed site also, and in your leisure time, you can also play polls and quiz in our site. So now, without further delay, I would like to welcome our today's moderator, Dr. Sangeeta Pahwa ma'am. Ma'am is professor and head of Department of Obstetrics and Gynecology at SRGD Medical College, Amritsar. She is the founder and president of Amritsar Menopausal Society. During her post-graduation, she got first prize in paper presentation at Kota. So now I would like to hand over the session to you, ma'am, to start with the scientific program. Over to you. Ma'am, please unmute from your end.
Before we finish the chief guest address, can somebody call Dr. Sonia Malik also so that we can be ready by the time the guests come?
Shobna ma'am, actually, Sonia Malik ma'am has sent the message that she will join at 6:30 p.m.
She has sent the message on the group.
Yes, ma'am.
Dr.
Yes,
Shobna,
ma'am.
look
Yes,
at her
ma'am.
message. Dr. Shobna, you are muted.
Okay, then we will continue without her initially and then let her join later, right? Yeah. Go on, Sangeeta.
Good evening to one and all. At the outset, I thank Almighty to provide me a chance and ability to conduct this task. On behalf of our Honorable IMS President, Dr. Shobna Mohandas ma'am, Secretary of IMS, Dr. Anju Soni ma'am, and I, Dr. Sangeeta Pahwa, President, Amritsar Menopause Society, we welcome you all to this webinar on pelvic pain. Pelvic pain is not talked about often. It's a strain, it's a suffering, it's affecting social life as well as family life. Today, we are having a galaxy of experts with us to discuss on this topic. To begin with our Honorable President, she is truly a pioneer of our field. We are lucky to have a leader like her. I express my gratitude for her unconditional support, invaluable guidance, and sympathetic attitude. Thank you so much, ma'am, for believing in our ability and motivating us for organizing this webinar. Before we start, I would like to express my sincere appreciation to ClearNet team for helping us and providing us this platform. Debolina, can we have the slide of Ambuja ma'am? It gives me immense pleasure and proud privilege to introduce and acknowledge Ambuja ma'am and Dr. Sudha Sharma ma'am for gracing their presence on this occasion as guest of honor. Both of them have been pillars of support in our academic and scientific activities. I have learned a lot from both of them and hope to bring our society forward in coming years. Now I invite Dr. Ambuja ma'am, who is President, Indian Menopause Society 2021. It's not elect. She was President 2021. She has been retired professor and head of the department from Osmania Medical College, Hyderabad, visiting Professor Savita University, Chennai, President Family Planning Association, Hyderabad branch, faculty and resource person.
Not
Yes,
necessary, Sangeeta. Thank you for your introduction. Thank you very much.
Now I
We'll
invite
go
you,
ahead
ma'am,
with
to say some words.
Yeah, and thanks, Sangeeta, for arranging such a nice topic from the Amritsar.
Thank you, ma'am. Thank you, ma'am. Thank you very much, ma'am, for nice words. I request now Debolina to show the CV of Sudha Sharma ma'am. Sudha Sharma ma'am is a former
I didn't
secretary.
tell anything, Sangeeta.
Yes, ma'am.
I didn't talk.
She has to continue, Sangeeta. Let her finish.
Okay. Yes, ma'am. Yes, ma'am.
Dr. Ambuja has to give her address.
Yes, ma'am. Amritsar.
Nothing much, Sangeeta, just to say that the start of the year is very good, and every Tuesday we are ready with the programs what Shobana has started, and topic is also very good and day to day topic, and definitely we get out of 10, 3 or 4 cases are the pelvic pain, whatever may be the reason. Simple reason like constipation also gives the pain like that. You have selected such a good topic, and the speakers are also so good, and we would like to hear and learn from you all what is new in the pelvic pain. Thank you for arranging, and thanks for inviting me for this webinar.
Thank
We
you
have
very
to
much.
start something with the past president. No, that's the beginning of the program has to come from an important personality. So that's why it's nice to start this webinar series with your guest.
Yeah, this is a very good thing that every Tuesday waiting like this, we are waiting for the webinars. What's going to come this time? What's going to come this time? Very
Next
good
is
start.
Hyderabad.
Yeah, our people are ready.
Yes.
I think they are corresponding with you, no, Shobna?
Yes.
Yeah.
Thank you very much, ma'am, for your nice words. Now I request Sudha Sharma ma'am to enlighten us with her wisdom. She is Secretary General IMS 2021 to 2022, Honorary Professor.
Thank you, Dr. Sangeeta, for
Thank
those
you.
kind words. Very good evening, everyone. I am finding, the chief guests over there, Dr. Ambuja, Dr. Shobana, Dr. Ragini is there, Dr. Anju is there, and everyone over this platform, a very good evening. And I would like to congratulate Dr. Shobana, Dr. Anju, Dr. Sangeeta for, for organizing this event. Dr. Shobna, a very good start, as Dr. Ambuja has said. A huge congratulations. And the topic is so very important. Pelvic pain. One of our male gynecologists, he always says that the symbol of, a female after 40 is pet dard, kamar dard, pet dard, kamar dard. We always tell him that you don't know what does it mean, the pelvic pain. It is such a vague problem and such, devastating problem for the female, but very less talked about. And what I have felt is many times, if you, look into their symptoms, if you go into the details, apart from organic, this thing, they will, come out with some psychological problems. They will always relate it with the sex also. So you have invited such, galaxy of speakers. We are waiting to hear more from them, and all the very best. And thank you for making me a part of it. Thank you so
very much, Sudha ma'am. Thank you very much, ma'am. Now, without further ado, I would like to welcome Shobna ma'am, to deliver her presentation on pelvic infection. Shobna ma'am is President Indian Menopause Society. As we all know, ma'am is really doing hard to carry it forward, and we are still in the nursery because we started in March 2021. Playpen is over ours, and now we are in nursery. And Ragini ma'am has done a wonderful job after starting Amritsar Menopause Society. And Shobna ma'am is chairperson, Women Doctors Wing, IMA Thrissur. She's president, Mission Pink Health, IMA Thrissur.
20 minutes.
Past vice president, secretary general, website committee chair, Quest chair, IMS. Member Foxy FDA committee. Past member Foxy endocrinology committee. South Zone coordinator for Foxy stereoscopy workshop 2011. Vice President IMA Thrissur 2016-2017. She has authored 2 textbooks in gynecology. Ma'am, we would like to read them. If you can provide us your textbooks. Contributed chapters to several textbooks and invited speakers and at more than 200 venues. Now, I would like to invite today's chairperson, ma'am, is somewhat late, Sonia Malik ma'am, who is really an amazing personality. As her name explains, she is having beauty not only of the face, but also of the heart and soul. Because in Punjabi, we used to say Soniye, which means Soni. So Sonia Malik ma'am is just like that. And now I would like to invite Shobna ma'am to deliver her lecture. Please, ma'am, now diocese is yours.
Yes, thank you. Thank you, Dr. Sangeeta, for agreeing to host this event. Is this a panelist link or is it the delegates are only 10 people here?
No, ma'am, it's only the faculty link. Means the speakers are only here.
I think there is a different faculty link and different panel link.
Okay, okay,
Members are different.
okay. So I will just share my screen first. Yes, so good evening, ladies and gentlemen. I thank you, Sangeeta, for organizing this program. I had initially given my topic as pelvic infections, but I said I would be talking about antibiotics. So the title was changed, but I hope you don't mind if I talk about pelvic infections either, right? So PID, as we know, can come from the endometrium, salpinx, mass, or peritonitis, So this is could cause endometritis, abscess, salpingitis, pyosalpinx, and bilateral lower abdominal pain is the most common presenting symptom. But patients might just come and say, I've got white discharge, and if you don't do a PV, you'll miss it. Patients might come with irregular periods and you'll think it is hormonal, you'll miss it. Post-coital bleeding and abnormal uterine bleeding also can be endometritis. So when to start antibiotics in all these common conditions, which you think is actually hormonal, that you have to decide. It's not everybody will come with dysuria, fever, nausea, or vomiting in the last stage. Even right hyperquadrant pain. Mimicking cholecystitis can be having a perihepatitis manifestation of a chlamydial infection originating in the pelvis. It's so, these are all things that we all see. Now, these are the studies which show commonest reason is abdominal pain, then comes backache, then vaginal discharge, then fever, then malaise, and then dyspareunia. So we are all good if we have to rule out ectopic appendicitis and endometriosis. But after having ruled out that, you have to answer the patient's question. How did I get it? Is it a serious problem? Because when you get a cough or cold, they don't care. But if you say you've got infection in your uterus, immediately, will my uterus be removed? What will happen to me? Will it become cancer? And you have to answer them. And you say that organisms like chlamydia and gonorrhea are the most important. So gram-positive organisms, And so bacterioids, Gardnerella and all are there. But basically, gonorrhea is the one which you have to treat. And also even anaerobes, streptococcus, ureaplasma, hemophilus, all this is there. So that is where the cocktail of antibiotics have to be given. Because many organisms are involved, This is a graphic representation of what I just told you before. So it can also lead to cervicitis, and you have to do a cautery of the cervix even in the end of your treatment, not just give antibiotics. Otherwise, it will recur. So you have to put your speculum in all patients of PID. So the flora has to be changed. Of course, you can tell the patient, you may be having receptors which will attract E. coli. You may be having some enzymes which will attract E. coli. So there is a genetic predisposition to it. But generally, it is coming from the husband only. And so primarily, it is chlamydia trachomatis. But then secondary, there can be colonic genitourinary or IUD causes of PID. What will happen if you don't treat it and you go on treating for endometriosis or hormones or UTI or something like that? There can be pelvic adhesions, abscess, or tubal block. So how do you diagnose it? One is cervical motion tenderness, uterine tenderness, and adnexal tenderness. And it's basically an empirical diagnosis. And endometrial biopsy, TVS, and all can show some things like this, but only tubal wall thickness, incomplete septae with tube, fluid in cul-de-sac, cogwheel sign. All this is like you can talk in books, but basically tenderness is that which you have to treat. This is the tubal wall thickness, and this is the fluid in cul-de-sac. That is a cogwheel sign. Thickened uterosacral ligaments on CT scan, you have to be good at CT. Thickening of the tube can also, but how can you send a patient for CT just for PID? It's not practical. So you can also find geo abscess, fluid-filled fallopian tube, and PCOD like ovaries, it will be misdiagnosed. But if there is fluid in the pelvis, you please treat the patient as infection, not as PCOD. So now, what is the drugs? Gonococcus, I told you, is the most common, and you have to give one shot of ceftriaxone. I don't know how many of us are giving. Doxycycline and azithromycin and quinolones are very famous with all gynecologists, but that will cover only mycoplasma and ureaplasma. And anaerobes are usually covered by all gynecologists, that is metronidazole. But we never give that one shot of ceftriaxone. But the average prescriptions are 7-day prescriptions of doxycycline, 7-day prescriptions of Taxim-O or Cefixime, and some people give azithromycin. But CDC, Government of India guidelines always says you give one shot of ceftriaxone, plus you give metronidazole for 14 days plus doxycycline. Nobody gives a single shot of ceftriaxone, and not many prescribe metronidazole for 14 days because patient will start vomiting. What is the US CDC PID guideline advises that metronidazole may be considered to provide additional anaerobic cover, but does not mandate its use. So what was given in the Indian guidelines in 2015, the US people are saying, you are not a criminal if you don't give metronidazole for 15 days. So it has become a may. And 2017 European guidelines are saying that it can be discontinued in patients with mild to moderate symptoms only if they develop drug-related side effects. Basic side effect is your mouth starts tasting like iron. And in 2019, as the years go by, Cochrane analysis does not support the routine use of metronidazole in the treatment of women with mild to moderate PID. So the revisions are coming. So metronidazole is now not mandatory. So should we push our doctors to follow the old guidelines? Should we have a study from our own practicing doctors and revise the guidelines? But I look into some of the regimens which do not require injectables in the outpatient. And when I told you have to give one ceftriaxone when you give doxycycline, let us think of the other regimens that are available right now. One is you give 1 dose of Cefixime plus azithromycin single dose plus metronidazole for 7 days, or levofloxacin 500 orally once daily for 7 days, or twice daily for 14 days, with or without metronidazole. Okay, this is 2011 guideline. There are studies, 4 randomized control studies, which says moxifloxacin 400 milligram once daily for 14 days. 4 large randomized control studies have demonstrated it. It is little costly, but it is definitely worth giving moxifloxacin. In many of my resistant patients, I have given moxifloxacin. Little costly, yes. Empiric treatment of gonorrhea and chlamydia is recommended for a sexual partners for the past 60 days. That is there. Empirically, we always treat patients when they come with vaginal discharge. But empirically, treatment to a partner for PID is just yet to percolate into the older generation of gynecologists. Although it is there in the guidelines, it is not percolated to all the gynecologists. So only if the failure to improve is there, then only you have to give parenteral therapy. And after 2 to 4 weeks, after therapy is recommended, is adequate clinical response to treatment, compliance with oral antibiotics, screening and treatment of sexual contacts, and awareness of significance of PID and its sequelae. So these are the things that we have learned so far. Now, when will you give inpatient treatment? When patient does not respond clinical to oral antibiotic therapy, you have to admit. Patient is unable to follow or tolerate an outpatient oral therapy. Patient has severe illness. Many of these patients of mine who cannot tolerate it, I put in an IV line and give them ceftriaxone dose. I have even given meropenem, let me tell you, and I have sent them home and they take it from some house nearby, and that is also possible. But yes, generally when they are not responding to oral, you have to admit that is the way people do it. And once you admit, you have to give Cifotitan 2 gram IV every 12 hours. Plus you have to give your doxycycline to cover the chlamydia. Or clindamycin every 8th hourly with gentamicin. And continue the treatment for 2 days. And then later convert into an outpatient treatment and send her home. This is 2016 review. Now, uncertain diagnosis and this thing, you will get a pelvic abscess. I had a patient who had got an ovarian mass, and then they are going everywhere saying it's only an ovarian mass. You can leave it alone. You wait. But that ovarian mass was an ovarian abscess, and once you open the patient, it's very difficult to look at what is happening because there are adhesions everywhere and you can't even find where it is. So you have to be very careful that these things do not happen to you. The ovarian abscess burst at laparoscopy. I'll show you where it is bursting. And this can even happen with diverticulitis. I'm sure the panel discussion, Sangeeta will discuss about the diverticulitis presenting as ovarian abscess. So this is what, because this ovarian abscess need not be coming from the ovary, it can even be coming from a diverticulitis. But it's very important that you diagnose it, because ovarian mass, everybody thinks it is a functional ovarian cyst, and pain, then they think it's just a mild infection. But this you have to be careful about it. And you have to differentiate it from hemorrhagic cyst and other things. So cervical movements, and I think everybody knows. High count and CRP, you have to check for all patients. We miss out on all this. That is the main problem. So after an ovarian abscess is there, you have to admit the patient for 24 hours. Wait for her to become hemodynamically stable. If you don't wait, what happens after that, she'll go into septicemia. And you may even lose the patient. Actually, unless and if she's in septic shock or something, you please make her stable with the drugs and tonics and, vasopressors or whatever. And quite often, antibiotic therapy may be sufficient in many women. When no clinical improvement is noted within 72 hours, then you can even minimally drain the abscess, but you don't know where the drain will go. Suppose it goes into a bowel or something, that problem is there. And so you have to be careful in these patients. And when you put in a laparoscope, please look at the liver also, because chlamydial adhesions are seen under the liver. And septic shock, you can even do a percutaneous guided, ultrasound guided, less invasive technique. And if that doesn't work, you can do a laparoscopy, colpotomy, laparotomy, peritoneal wash, and whatnot. So this is another case where this was looking like ovarian cyst was diagnosed as, what, ovarian mass, and in a young girl. And I thought this first look that this is cancer. And actually I misdiagnosed it. She ran away from me, and finally, and even the granulomas, it did not show TB, but later on it was diagnosed as TB. So this can be easily missed in a patient with a 6 centimeter cyst, and the CA120 was also high. So you have to you can fall into trouble when you have tuberculosis. So this is another patient with a ovarian mass. I will leave that out. So finally, whenever you have a patient with pelvic infection or ovarian mass, please rule out ectopic pregnancy. There is a high risk of preterm delivery and maternal morbidity. Avoid doxycycline and fluoroquinolones in pregnancy. Combination of cifotaxin, azithromycin, and metronidazole for 14 days may be tried. This is FOXI and ICOG guidelines. I'm sure Sonia Malik may be part of it. We don't know. She's part of all FOXI programs. How do you deal with a patient with HIV? They should be treated with the same regimens. Low CD4 count should be an indication for hospitalization. There is an increased incidence of Mycoplasma hominis and Streptococcus in these patients, and there is a more incidence of TO abscess in these patients. This is FOXI guidelines. So now finally, I would like to say injection ceftriaxone as an injection for OPD PID is there in all guidelines. Whether you can practice it, I don't know. I have not used it. I usually use a lot of cephalexins. There is no evidence, but a lot of experience I do have. Use of ofloxacin 400 BD is the guideline, but how many people can take that much of drug? So vomiting will be there. So etiology of anaerobes of and so I do not use that high. If I want to use it, I use moxifloxacin. Etiology of anaerobes and causing PID is being revised. So you may be excused if you don't give metronidazole. But for God's sake, always treat your patients for 14 days. It's there in all guidelines. And in my patients also, I find that unless I treat it for 14 days, they will just go from one doctor to another doctor to another doctor. So moxifloxacin and levofloxacin are newer options. Use of ultrasound, CT scan, and MRI give a very clear picture in diagnosing sequelae of PID. And finally, before leaving, all of you are welcome for the Calicut IMSCON. And this is just a small video for 1 minute. I will stop it after that. And I hope you all do come to Calicut in February 2023. It's a lovely place. There is a hill resort near Calicut where you can come. And after good academics, we welcome you to that. Thank you so much, Sangeeta. I'm on time. I finished in 20 minutes.
Thank you very much. Thank you, ma'am, for such an informative, interacting, interesting, as well as crystal clear lecture. And really, we are not giving an OPD ceftriaxone. Whenever we are admitting the patient, then only we are giving ceftriaxone. Otherwise, on OPD basis, only doxycycline and metronidazole we are putting. The patient, that too only for the 7 days. Again, patient is coming after 7 days. Then we are again giving for another 7 days. But totals 14 days, I've never prescribed to any patient. You are right.
That is why I'm giving this presentation
yes,
today.
You are right.
Sonia, madam.
Welcome, Sonia ma'am. Sonia ma'am, I have said one word for you that in Punjabi, we used to say Soniye, which means Sundar. You are not only beautiful by face only, you are really beautiful at heart and soul also. That is for
Thank you so
from my
much,
side.
bhai. ਤੁਸੀਂ मैंने मेरा बिल्कुल दिन बनाता. Thank you very much, Punjabio. Thank you so much for this compliment.
Thank you.
Thank you so much. It isn't true though. I don't know. Anyway, I'm sorry for coming late. Really, Doctor, both of you, both my president and ex-president, Dr. Ambuja, both of you. I'm sorry I came towards the end. I just finished another webinar. That's why I got.
Oh, you are a very popular person. You must be getting called to all the webinars. I'm very sure.
It was only today. Anyway, thank you for this wonderful overview of antibiotics in pelvic inflammation. Just a little, I missed most of it. I was there only towards the end. But I think in the elderly patient, we'll have to be a little more careful about our choice of antibiotics. And basically, the cause of pain may be slightly different in our patients when we are talking of pelvic pain. I don't know, Shobna, you may have talked about it in the first part of your lecture. I wasn't there, so I'm just asking you.
Older people specifically, I did not mention that is there, but I did mention that ovarian abscess can be misdiagnosed in the older woman because 3 to 4 centimeter ovarian cyst, everybody says wait, and that is sometimes an ovarian abscess, and that's very dangerous.
Okay, yeah.
That is there.
So and I think the dosage will also have to vary. We won't be able to give that much of dose in the elderly patient.
Madam, what is your regimen? We would like to learn.
I don't deal with these patients anymore, Shobna. I don't have a personal experience because I don't.
Okay, you're dealing with infertility only.
Yeah, only with infertility. That's or perimenopausal patient. And in the perimenopausal patient, if you have pelvic inflammation, we are generally giving the usual antibiotics, like you have said, the cephalosporins. And of course, I also give a lot of IV antibiotics to my patients, especially endometriosis in the perimenopausal age group. When they come for infertility, we are starting it with IV antibiotic. And as you said, ovarian abscesses can be missed, especially in endometriosis. You know, when you have very bad endometriosis and you think it is actually a teomas with pus, and we think it is an endometrioma. So I'm sure my endoscopy colleagues will be able to tell us more about that. But this is what we sometimes find in our patients who are coming to us at perimenopause for infertility also. But yes, you do have to treat them with IV antibiotics. Oral antibiotics are not going to help at all. No.
But would anybody like to give any quick rejoinders? Ambuja madam, Sudha madam?
Sudha is saying something.
Yeah. Dr. Ambuja, you want to say something?
Yeah. Shobna, I prefer to give ofloxacin, and instead of metronidazole, I give tinidazole. Again for 10 days to 14 days. Never it for 3 days, 4 days, 5 days.
But
no, it's-
ofloxacin 200 BD is enough for you, your
no,
patients?
no. Yeah. BD for 14 days.
But
And then
200,
more than
200.
that, it is yeah,
200.
200.
Yeah, because the studies
And-
are saying 400.
400. I
But
give
our patients, I don't know, they don't tolerate 400.
Yeah, that's
Somehow
what
I'm
I'm
giving
saying. But
200
200, your patients are working with means they'll respond to 200.
200 BD.
Okay, so we learn from
And,
each other. Sudha,
Other
Hotels.
than tinidazole, I am giving metronidazole.
Okay, that's
I'm
that
always
many of
giving
us
the
are using
tinidazole.
ornidazole, tinidazole, and
Because
everything. That is
the
there.
vomitings are less. And
Yeah.
along with the tinidazole, for everybody, I am giving Zofar. It is very good reception. They are completing the dose. Otherwise, metronidazole, because of the vomitings and the taste, the metallic
Hmm,
taste that will be
okay.
there, they don't continue the treatment at
It's a
all. 2
good
days,
tip.
3 days.
Okay.
And so invariably, I'll add metronidazole for them and then one analgesic. Then only they will continue to take the thing. This is a combination like that for 4 things, whether they need it or not. Where I'll add the Zofar and then on analgesic, either dicloron or anything like that. It's
Okay.
definitely,
Okay.
so that is the treatment.
I
And
also always
I
give
don't treat,
some analysis with the
yeah.
pelvic pain patients.
And as you said,
Initially,
you
at
know,
least.
speculum examination seeing, and if there is any type of vaginal discharge, watery discharge, anything little abnormal, if you find, I give clotrimazole, vaginal pessaries for 3 days. Definitely,
Yeah.
it is going to help the patient, and
Okay.
the pelvic pain comes down. That's what they complain of, the dragging
Okay,
sensation
okay.
in the pelvis.
Okay. Okay,
Dr.
Sangeeta, you can
Shobna,
carry.
Dr.
Yeah.
Shobna, just 1
And
minute.
the
Dr. Ambuja,
probiotics
just 1
also.
minute, a word of caution. Ofloxacin is also a second line drug for genital tuberculosis, you know.
Okay.
So,
Oh.
yeah. So if you have to give it in a patient of pelvic inflammation, just be little careful, because you know you are giving it only for 15 days and it is going to sort of may cause multi-drug resistance. I'm not saying, but you know, because it is a second line. I also give it. I'm very, very, very fond of ofloxacin myself, but I'm very selective in my patients, because if I think that this patient could be tuberculosis, we are generally now looking for endometritis also in these patients. If we think that this patient is chronic endometritis, then we do give ofloxacin, but otherwise I would be a little wary because of the risk of, you know, doing this. That's just
Yes,
a word.
you are very correct, Sonia.
Okay, madam. Madam, now we have to stop the discussion because we have one more panel and one more talk.
One more drug which you would not have tried. This is the clarithromycin. It
I'm
gives
doing
a very
it.
good
I'm
result.
using it. I'm using it
Yeah,
again.
I am using.
Again,
I'm
second
really
line.
fond of it. If they don't respond to the first line.
Again, second line.
clarithromycin gives
Again,
a
second line.
Very good tip.
definitely
Very good tip. Very
Yeah.
good tip.
But again,
Okay, now,
not
madam, we will
question.
go on.
I just
and
want
then,
to add.
Sorry.
I
Yeah,
just
okay,
want
so
to add
quick,
one
quick,
thing.
quick.
Say
Yeah,
something.
Dr. Shobna, you very clearly mentioned that, you know, Jeffcott also writes first, you know, a shot of this monosef, and then followed by, you know, doxycycline. But I used to do the same practice earlier, but 2 of our patients in the medical college, you know, they had reaction to this drug, and yeah, it died. I just want to make it clear to everyone that after that we have started
but you
doing
have to give a test dose, then only give it.
Yeah, earlier nobody was giving the test dose.
But nowadays nobody gives it without test dose.
So don't give it without test dose. Yes, 1 shot this, then followed by doxycycline 2 weeks. That's the, you know, this thing. And if you have ornidazole, my drug of choice is ornidazole with,
I also use it quite a lot. Yeah,
doxycycline.
Okay.
And ofloxacin in those patients who are, you know, not very fulminant PI.
Lovely pearls from all the seniors. Sangeeta, we should not run late because you've got the panel and then Ragini has to come. Yes.
So let's move now to the next session of today's evening. That is panel discussion on pelvic pain. Today we are having with us, who is none other than Dr. Anju Soni ma'am. She is Secretary IMS. She's really talented and hardworking person. And she's President Jokes, Jaipur Menopause Society 2017-18, Vice President Jokes 2013-2015, and she's Secretary IMS Jaipur Chapter also in 1517. Patron member PCS Society, executive member Jones Isopap Narchi, International Menopause Society member, Nose Zone coordinator Foxy Urogyne, committee member endoscopy
Thank
Foxy.
you. Thank you so much, Sangeeta. Thank you for your kind words.
Thank you, ma'am.
And I just remember the day I called you to do these webinars and you just agreed
Thank you.
immediately. That is a great thing. And today the topic you have chosen is again very difficult yet less addressed topic, and we really need to focus on this subject so that we can all let the women suffering go less. When we start the panel, then I'll be able to give more inputs into this very important topic, and that is when I will give my remarks also. At the moment, I would like you to start your panel and invite all the panelists.
Yeah. Debolina, can we have series
I'm there only. So
Yeah,
that is not
Sangeeta ma'am,
required. I will give my comments. Is Dr. Ragini not there? She's not giving her lecture first. Hello.
Hello.
I am very much here.
आपका lecture नहीं हो रहा क्या?
Debolina, can we have panelists? Series of panelists.
मेरा second lecture है, मुझे नहीं मालूम क्या कर रही है संगीता.
So we are having today with our panelists, Dr. Archana Agrawal.
Ma'am, I would request if you could stop your sharing. I will share the.
Yeah, I will stop sharing.
Okay.
It's okay now? Debolina, I have stopped. Yes, we are having our first panelist, Dr. Archana Agrawal. She is treasurer IMS Amritsar Menopause Society also. She is consultant City Hospital East Mohun Nagar, Amritsar, ex-consultant Mahabari Charitable Hospital, and ex-AP SGRD Medical College. She is trained in ART at ICET, trained in laparoscopy, and life member Foxin and ISA. Now I come to the next panelist, Dr. Kavita. Dr. Kavita Bhatt is professor and head department of
Ludhiana. मेरा session आ गया.
President Ludhiana Menopause Society, editorial board member, national and international journals. She has many publications in journals and chapters and books. She is executive committee member of Punjab ISAR and Foxy. Best Clinical Teacher Award in 2016 she got. Wonder Foxian Award 2019. And she has got Manyata Champion Award 2020. Next panelist, Dabalina. We have seen Dr. Ashima. She is professor at TMC, Ludhiana. She has received various trainings in IUI, IVF training, laparoscopy, and she's organizing chairperson for MRCOG Part 1 post 2015. She's co-member of Foxy National Task Force COVID-19 in pregnancy. She is organizer for Eagle Project on laparoscopy for postgraduates at DMC in 2020. Next, Dr. Pathak. He is working as Senior Divisional Medical Officer in Northern Railway Divisional Hospital, Firozpur. He is founder secretary of the Firozpur OBG Society. His special interest is in high-risk pregnancy and minimally invasive surgery, and is doing that a lot of work there also. He has presented and published papers in national and international journals, received CMD Award twice for excellent work in Northern Railways in 2009 and 17, contributed chapter in Foxy Focus on RPL, first edition 2018, winner of this competition state and national level, including AICOG 2017, and part of the scientific sessions at state and national level AICOG. Now coming to the panel discussion, my fifth panelist is absent because her uncle is not well. So my third year PG will take up one question. Shomna ma'am, she is allowed to take that. I welcome you all. So why we have chosen this pelvic pain topic? Because we all know that 20% of the patients from 18 to 49 years are suffering from pelvic pain for more than 1 year. And more than 20% of the hysterectomies are doing because of this pelvic pain only. And 1/3 of the laparoscopies are done for this pelvic pain. In 1/3 of the cases, endometriosis is responsible for this pelvic pain, and in 15% PID is responsible for pelvic pain. And it is really devastating for the quality of life of the patient. What is pelvic pain? It is a pain in the lower abdomen and pelvic region. It can be acute, sudden in onset, sharp rise, short course, which is lasting less than 2 weeks. It can be subacute or it can be chronic. It can be chronic pelvic pain syndrome when no cause is found. It could be cyclical. It could be dysmenorrhea, which can be primary or secondary based on the anatomic pathology. It could be dyspareunia, which is the pain associated with the sexual intercourse. Chronic pelvic pain, according to ACOG, it is non-cyclic pain, which is lasting 6 months or more. According to RCOG, it is intermittent or constant pain in the lower abdomen or pelvis of a woman of at least 6 months in duration. It is a symptom, not a diagnosis. It presents in primary care as frequently as migraine or low back pain and may significantly impact on a woman's ability to function. Living with any chronic pelvic pain carries a heavy economic and social burden. Now, coming to the first case, I would like to invite Dr. Pathak that a patient of 40 years is coming to you and she has presented with pelvic pain since 6 to 8 months, for which she is taking medications off and on. When she has
You're not on presentation mode. And your voice is not audible to me. I don't know why.
I'm not audible.
Can you tell Debilina to check?
She's audible to me.
I
She's
can't hear you
audible
from
to
my
me.
laptop because I've just joined from my laptop.
No, she's audible and we can see her presentation, Anju.
Should I continue, ma'am?
Yeah, yeah.
Her ultrasound findings revealed that uterus is normal, ovaries are normal.
I can't hear anyone.
Ma'am, you can rejoin. Anju, ma'am?
Anju, switch off your video. Switch off your video and then see.
She's worried that in spite of normal ultrasound and medication, her pain is not getting relieved. This question is to Dr. Pathak. How will you evaluate this patient, Dr. Pathak?
Yeah, very good evening. Sorry for joining late because of net problem. This is a 40-year-old female at 6 to 8 months of pain. So this fits the criteria of chronic pelvic pain. We have to evaluate the patient by doing first our history. For history, we have to know whether the pain is cyclical or the acyclical, whether it's a relation with the menstruation or not. Going by the old chart, the onset, when and how the pain start, whether there is any change of over the time, like early menstrual change, pain increase or not, the late menstrual pain or not, whether it is specifically localized to any particular site, and how long does it last? It will last a few minutes, hours, or whole days, persistent or not. It's what the character of the pain. It's a burning, lightning, tingling, because this all gives us the evaluation of the type of pain, how the pain, the origin of pain. So whether there is any elevating factor or not, the aggravating factor or not, we have to know whether it's relieved with medications or not. Whether is any particular position which makes it worse or not, whether it's sitting or standing or lying down make it relieved or not. Whether any associated symptom gynecology, she is in the reproductive age group. So whether there is any case of dyspareunia or any abnormal uterine bleeding, discharge, infertility, constipation, diarrhea, you have to look at all the organs. You have to find all the organs, whether uterus, tube, ovary, the GI tract, the musculoskeletal system, the muscles, everything you have to look after, the bladder, bowel, and whether there is any history of radiation or not of the pain, the temporal time is more with the menstrual cycle or not, the activity, increase with activity or not, and you have to grade it the severity, whether I say 0 to 10 severity.
We have to take the thorough history and examination.
Yeah, then we'll go for the per speculum, per abdominal examination. The per abdominal, we will see whether there is any specific trigger point or not. And if there is any trigger point is specific, the patient will localize the trigger point. If there is neurological pain specific, then the patient will be able to localize the pain. Otherwise, in case of chronic infections, the chronic pelvic PID, there will be generalized pain abdomen. And we have to also look for the per speculum examination to look whether any nodules per speculum examination, nodule or discharge. So that will suggest of history of any infection, chronic infection or acute infection. And we can look for the per speculum nodules if there any nodules palpable or visible on the posterior fornix or the laterally. We can, by doing pervadal examination, we'll have to see whether there is any mobility, restricted mobility or not, whether the fornixes are tender or not. And also a lot of time when there is constipations, the loaded rectum also causes chronic pain. So we have to rule out the constipations as well as in these cases.
So we have to take the thorough history taking, and in thorough history taking, severity of the pain is also very, very important. 0 is none, 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe, according to Warren Grant Clinical Center Scale or NIH. So evaluation, we have to see for the depression, anxiety, emotional, physical, and sexual trauma also, quality of the life, and criteria to assess with the diagnosis of, as you have rightly said, whether she is having any GIT symptoms also. So thorough history taking of the medical, surgical, or any medication, prior evaluation for the pain with outcome, because we have to see how much medicines she has taken and how much relief she has found with that medication. So we have to thoroughly review all the prior, if she has undergone any operation for that pain, that also has to be taken into consideration. So physical examination, you have told, we have to go for the pulse speculum and bimanual examination, all the things, spleen, kidney, uterus, all the vowel sounds, inguinal area, liver, and all body landmarks have to be examined properly. And importance of PSPV examination, bimanual examination is done. Pain elicited beneath the urethra may indicate urethral diverticulum. Pain with the anterior vagina palpation, interstitial cystitis. Large uterus, we all know it could be because of the fibroids. Globular tender uterus is consistent with the boggy uterus with the adenomyosis. If it is immobile, it could be because of the adhesions or endometriosis, diverticular disease, or pelvic congestion. So importance of PV is to diagnose pelvic pain in anterior fornix. It could be cystitis, and deep posterior fornix palpation will tell you about the all the things we find in the PV examination. And importance of the per speculum is we can rule out cervicitis also. Now, causes, you have rightly said, common causes are interstitial cystitis, adhesions, endometriosis. We all are watching this endo and adeno in our OPDs in day-to-day practice. Neuropathic pain, gastrointestinal problems, pelvic muscle spasms. These are the common causes of the pelvic pain. Now, how will differentiate, Dr. Pathak, between whether it is pelvic in origin or it is because of the GIT symptoms?
In the GIT symptoms, the pain usually increases with the intake of food and passes into defecation. Because if there any adhesion, it stretches the limits the stretching of the gut, and so the pain is increased. And also the pain, the GI symptoms are altered, like the patient may complain of alternate diarrhea or the pain during defecation, or they may be bleeding also during defecation. There may be hematuria and all the other complaints also, the GI symptoms associated with the GI problems. So we have looked for the whether rule out the ulcerative colitis, intestinal Crohn's disease, or in the appendicular masses also there sometimes there can be pain, chronic colicky pain abdomen. So in GI symptoms, mainly they are more of the colicky in nature rather than the other pain.
So it has good association, that pelvic pain has good association with the periods also. It is cyclical, menstrual, or premenstrual, or it could be ovulatory pain. It is because of pelvic etiology. But IBS can also come on premenstrually. It is worse after eating. IBS, we have seen one, our postgraduate student, she's suffering from IBS, and whenever she is eating, it gets worse. When she used to defecate, she gets relieved, and it is also seen with the stress. Dyspareunia is traditionally associated with the pelvic causes, but it can also occur with IBS, but tenderness over sigmoid colon is found only in IBS. If a patient with chronic pelvic pain complains of sudden abdominal pain, we can think of appendicitis also if it is on the right side. Thank you so much, Dr. Pata, for giving your valuable inputs. Anju Soni ma'am, would you like to add something in this case? Anju ma'am, are you there?
There, but I couldn't hear anything because there was some, problem. I couldn't listen anything. Now my laptop is well connected. I will give my inputs in next case.
Okay, ma'am.
Yeah, I couldn't hear. There was some problem. I joined 3 times and it is okay now.
Shobna ma'am, Ragini ma'am, and Sonia Malik ma'am, would you like to add something?
I would like to add that we must take history of the somatic, psychosocial, and the drug abuse and the substance abuse, because if some patient is dependent on some drugs and that is withdrawn, that can also cause some kind of a chronic pelvic pain. So substance abuse and dependence history should be sorted.
Yes, definitely, Dr. Ashma, you have rightly said we should take the history of drug abuse also and psychosomatic problems also. It's very good. We have to take that history also. So now my next question, moving towards to Dr. Archana Agrawal. A patient of 45-year-old is coming. She has undergone hysterectomy and now she's complaining of lower abdominal pain, which increasing on lifting heavy weight. What is your probable diagnosis? Dr. Archana, are you there?
Yes, thank you, Dr. Sangeeta. Hello, everyone. I'm Dr. Archana Agrawal from Amritsar, Punjab. My diagnosis is myofascial pain, or you can say myofascial pelvic pain syndrome. It's a patient can have local or referred type of a pain, and usually it is the pain in the pelvic floor and the connecting fascia. The tender points in the skeleton muscles or myofascial tender points are the typical things which is a patient has, and usually the cause is the post-surgical, or it can be nutritional deficiency or psychological causes, stress, hyper-response, personality. And the signs and symptoms are that is the stimulation of trigger points in the pelvic floor causes referred pain. The typical thing is that it is not in the classical dermatomal region where the nerve supply is. It's a vague pain. And the myofascial trigger points are localized, often painful lumps in the nodules like things in the muscles or the connective tissue of the pelvic floor. And referred pain can be in the perineum, vagina, urethra, or rectum. The pain can be a constant dull pain or intermittent pain. It can be vague or generalized. It can be achy, heavy, or deep pain. It can refer to clitoris or rectum. It can be associated with constipation or pain before or after defecation, incomplete bowel or bladder syndrome, evacuation, and dyspareunia. On history taking, we find that after like in this case, after surgery, the patient is having this type of pain. And we can also ask her that whether the pain increases or decreases with the change in posture or which movement. Yes. And on examination, we'll find that the hammock of the pelvic floor is below the ischial tuberosity, which indicates the laxity of the perineum. And we can also palpate the trigger points. If we palpate perpendicular to the muscle band, we can feel the taut bands or the nodules. And when we press those nodules, the pain starts. Local twitch response can be also elicited. That jump sign, which is called jump sign, that when the trigger point is palpated, there is a twitching at the local area. Ultrasound can be done to exclude other pelvic pathologies, and vaginal culture should be done to remove the contagious causes. Some thermographic studies have also shown that trigger point nodules are having temperature 0.6 to 1 degrees higher than the
normal areas.
Other area. And the confirmatory is the local twitch response, the palpation of the nodules, and the referred pain pattern, not relating to the dermatomal region. And the management includes it is multidisciplinary. Usually the psychologist should be involved and the physiotherapist, and which psychologist will manage the emotional issues, and the physiotherapist will do help in doing the pelvic floor exercises to relax the pelvic muscles. in which the Thales massage is very famous in the physiotherapist. Medical management we can use the local anesthetist to inactivate the trigger points, or we can use the antidepressants to delineate the neurological pains. Patient should be educated that she should not do the Kegel exercises or the abdominal contractions, and the tight clothes should not be worn because they will increase the pain. Usually the prognosis is good, and after 3 to 4 months, the patient is relieved, and maximum it can take up to 2 years. Thank you, Dr. Sangeeta. Thank you, everyone.
Dr. Ashna. You have rightly said that when she is lifting weight and she's having pain, it is most likely myofascial nerve entrapment, because nerves are get entrapped, that is iliohypogastric or ilioinguinal nerves, that can occur with the transverse suprapubic laparotomy incisions or laparoscopic incisions also. It will not begin until weeks after surgery or even years following surgery, following vigorous abdominal wall stress with lifting or re-injury, which we all are doing whenever doing cesarean sections. We are pulling the muscles like hell. Nowadays, young generation, what they are doing, they after giving incision, they are pulling on both sides very badly. And symptoms are sharp burning, aching, pain, and paresthesia in the dermatomal distribution to the involved nerve. With entrapment, exercise or activity exacerbate pain, and rest or infiltration with local anesthetic relieves the pain. So a very simple test which can confirm on examination. This is Carnet sign, which we have started doing when we read about all this. Now we have started doing it in our OPD. This is very simple sign, that is Carnet sign. You say clinician identifies and palpates the point of the maximum abdominal tenderness in the resting supine position. Then patient raises both the legs off the examination table while the clinician palpates the abdomen again. Alternatively, patient can raise their head and shoulders over the bed, tensing the abdominal wall. What is positive Carnet sign? Well, when palpation of the abdominal muscles in the tense position, it elicits the same or more tenderness as the resting position. It is of the abdominal wall origin. Otherwise, it is of the viscera. So Carnet sign is very much helpful. This is very simple test which we all should do in our day-to-day practice. Diagnosis, tentative diagnosis we can make by giving that injection. If patient is relieved, it means it is because it is giving usually immediate response of the symptoms after giving 5 ml of 0.25 bupivacaine injection. And at least 50% of the patient experience relief, which lasts longer than few hours, even over following weeks. So management, Dr. Ashna has rightly said, avoid activities that lead to compression of the nerve, medication that is topical, local anesthetics, and antidepressants. So psychological support is very, very important. Surgical decompression of the nerve sometimes may be recommended. And trigger points, definitely, they are very, very important. What are the active trigger points? They are hyper irritable spots. What are that? They are the taut band of the skeletal muscles, and they are painful upon compression, produce characteristic pain, rough tenderness, motor dysfunction, and autonomic phenomena. And passive trigger pains, they are silent unless there is some triggering factor is there. So treatment, again, Dr. Ashna has rightly pointed out massage, relaxation techniques with the help of the physiotherapist, psychotherapy, and anti-inflammatory analgesics, muscle relaxants, or trigger point injections. So now I would like to hand over to Dr. Anju Soni ma'am to give her expert views.
It's very, very important thing you have discussed, because most of the time the cause is not in the pelvis, it's in the nerves and the muscles, and that makes the quality of life very poor for the patient. So detailed history and detailed physical examination, as you have said, is very, very important. And we must always, so many times these patients are referred to psychiatrists. I've seen patients being referred to psychiatrists for no rhyme and reason. And that is what is the main thing. So we must take a detailed history and how the life quality of life is being, hampered by this pain, and how much she is affected. Sometimes they withdraw from their society and surroundings, because they feel that nobody is believing that they are suffering, and actually they are suffering. And the doctors are also do not have, most of the doctors do not also have this knowledge. So as you said that, proper examination, proper history taking, and then ruling out the other gynecological or urological condition is very important, and examining them in detail and then giving them the different therapy which is not required, like for PID or for endometriosis, psychotherapy, massage and relaxation, and of course painkillers, and giving them confidence that this is there and you are suffering, we know that, but you become all right with the proper treatment given to you. It may take some time because it takes different time for different people. So that is what I wanted to focus on.
Thank you, ma'am. Thank you. Shubhna ma'am, you want to add something? Sonia Malik ma'am, Ragini ma'am, or any
Ragini wants
panelist?
to say something.
So what
I
want
don't know
to say-
whether we are running out
Sangeeta,
of
Dr.
time,
Ragini,
but I have been practicing trigger point injections with 20 ml of normal saline and 100 milligram hydrocortisone and xylocane for many years now, for almost 20 years. I just give it to the patients under the skin, and it's permanent. It's not just for a few weeks. Once you give it, it is lifelong. It never comes back. Yes.
So I just want to comment only one thing for the whole panel as a chronic pelvic pain, that chronic pelvic pain has a spectrum. It is not only gynecological problem, it's so many problems. Whenever a patient who is not getting treated properly by us, we should always think of referring those patients. There are two persons, they are very, very important when we go for the pain management. One is a pain management specialist. Specifically, many anesthetists are doing this practice today. And second is a physiotherapist. They really do wonder for specifically the trigger points, entrapment of the nerves. And third thing, when we operate, as this injection was just told, it is a very important thing to do the proper pain management at the time of the operation, so that pain is not centralized and it changes the somatic changes inside. Thank you so much.
Thank you, ma'am. Thank you. Now, my next question is to Dr. Kavita. What is pelvic congestion syndrome? Whether it is an empirical diagnosis or it really exists. Dr. Kavita, are you there?
Yeah, I am very much here, Dr. Sangeeta. Thank you for including me in today's program, and good evening to all my seniors. This pelvic congestion syndrome, I have never diagnosed in life. To be very honest, we always talk about chronic pelvic pain and we look for many entities lead to a chronic condition, that is pelvic pain.
Because in ultrasound, people are writing that pelvic congestion syndrome in ultrasound. They are giving us the reports.
So before this panel, I was reading.
Excuse me, but pelvic congestion is diagnosed only on a laparoscopy. We can see the dilated blue veins at the side of the pelvis very easily on the laparoscope. Otherwise, only a venography can diagnose it. When you do a laparoscopy, it's very easily seen. And the only treatment is Dapplot.
It's an entity which is really being treated by the vascular surgeons in detail. And there's a veins which are really dilated. And what you think in this varicose veins, like the veins are there in the pelvic congestion. And I think Dr. Kavita will tell in detail.
Because I've been reading about it, ma'am, and I was going through the pictures also. They have varicosities in the legs also. So basically it is because of the incompetence of the valves of the internal iliac vessels as well as the ovarian vessels. And incompetency may be because of the hormones, that is estrogen, or because of any obstruction also. And basically it leads to stresses of the venous blood, and therefore this congestion syndrome, it is also known as pelvic venous syndrome. And mostly it is seen that it is occurring in the younger age group, pre-menopausal, and after menopause, because it is estrogen related, it subsides. And very rightly ma'am said that it can be diagnosed on laparoscopy, but the gold standard is venography. And other methods like imaging, ultrasound, CT, MRI are also there, which may help. And plus you need to have a higher level of suspicion when patient comes to you and have ruled out other entities which lead to chronic pelvic pain. So those are some of the diagnostic methods for diagnosing pelvic venous congestion syndrome. And since you have shown on your slides nut syndrome,
That's
there
correct.
is something which is known as May-Thurner syndrome also. So that is because of the left ovarian vessel vein, which drains into the left renal vein, while the right ovarian vein will drain directly into the IVC. What happens on the left side is it gets compressed between the superior mesenteric vein and the aorta. So that is known as the nutcracker. Again, the stasis will be there and varicosities will be there. And May-Thurner is also because of the compression of the veins. So basically it is because the valvular incompetence is there and congestion in the lower extremities and the pelvic vasculature. So we have covered diagnosis. Shall I treatment also?
Yes. What are the symptoms and signs of this pelvic congestion syndrome?
So again, it will, as I have already said, it will affect the younger age group, and they will have all the symptoms of that heaviness, lower bloating, lower abdominal pain, and backache. And as such, clinically, I'm not very sure whether you will have any findings, only if it is associated with other entities of pelvic pain. And diagnosis we have covered, and then treatment basically hormonal. Okay, so sometimes
this is the laparoscopic findings of the dilated ovarian veins. And what are the treatment options, Dr. Kavita, for this pelvic congestion syndrome?
Since it is related to the estrogen levels and it is seen to be disappearing after menopause, so many people give oral contraceptive pills or hormonal therapy in the form of medroxyprogesterone acetate, danazole, GnRH, basically to suppress the estrogen levels. And also medical treatment can be given in the form of NSAIDs and other symptomatic relief. And usually they say invasive surgical methods should be avoided, but it has been mentioned that you can do ablation, and also the valvular competence can be increased by some vascular surgeons, like invasive vascular surgery can be there. Hysterectomy with salpingoophorectomy, people have written, but again, I have my doubts whether it will really help. People do resort to THPSO. I don't know whether anybody has tried this extreme method of treatment for pelvic congestion syndrome. At least I have not done this. I would like to hear from the other panelists also whether they are doing this invasive surgeries.
Anyone else want to add?
Dr. Kavita very well said about pelvic congestion syndrome. And one thing I would like to add that CT sometimes suggests about the pelvic varicose. And though the gold standard is venography, and patients do come with chronic pelvic pain, and where we are not able to diagnose what kind of a pain, and they request for a surgery. And there are patients when we operate and we see there is pelvic varicosity, and they do improve after hysterectomy. But before that, we did not know that it was a pelvic congestion. We treated her for a chronic pelvic pain, but intra-op there was pelvic varicosity, but they did improve after surgery.
Yes, Dr. Ashima rightly said that we are going for the hysterectomies for the chronic pelvic pain, but later on we come to find that it is because of the pelvic congestion. So diagnosis is made as well as patient is treated at the same sitting. So diagnosis can be made clinically, but it is difficult, as Dr. Kavita has rightly said, and imaging can be used to help diagnosis, and therapy as well. Laparoscopy or venography can also be used. It will show, ultrasound will show tortuous pelvic veins with a diameter of greater than 6 millimeter, slow blood flow or reverse caudal flow, dilated arcuate veins in the myometrium that communicate between bilateral pelvic varicose veins, sonographic appearance of the polycystic changes of the ovaries, and various Doppler changes are also seen in pelvic congestion. So treatment we have discussed that suspected ranges from the invasive hormonal suppression and behavioral therapy as well as TH with BSO, and various drugs can also be used, that is Daflon 500 BD for 4 months. Daflon is just like other varicosities, it can work, and medroxyprogesterone acetate Dr. Kavita has already discussed, and goserelin, NSAIDs, ovarian artery embolization, but long-term results are awaited. So multidisciplinary approach incorporating psychotherapy, behavioral pain management, or both is highly recommended. Now, coming to the next case, Dr. Simran, are you there? Simran?
Yes, ma'am. Yeah, I just want to.
Simran is my third year PG because Dr.
Good
Ashna
evening, ma'am.
Mary is out of station, and just now she has informed me she's going out. So Simran has opted that she will take this question. A 43-year-old woman presents with a history of THA with DSO for deep pelvic endometriosis 2 years back. She complains of pelvic pain from last 1 year. Pelvic examination shows fullness and tenderness. Ultrasound is showing pelvic mass of 3 into 3 centimeter. FSH is 11, which we have already done this, and her estradiol is 150 picogram per ml. What is your probable diagnosis?
So, ma'am, the patient has undergone total abdominal hysterectomy with bilateral salpingo-oophorectomy, but she has the pelvis mass of 3 into 3 centimeter, and also FSH levels and estradiol levels are normal. So, the patient can be of a ovarian remnant syndrome.
Okay.
So,
Then what
in an ovarian remnant syndrome, there is a history of oophorectomy, and the symptoms that are suggestive, there can be a presence of mass or the evidence as the FSH levels are high and estradiol levels are FSH levels are there and estradiol levels are normal. So there is evidence of persistent ovarian function.
Okay, what are the risk factors for this?
Ma'am, the risk factors can be the incomplete removal of the ovary, which is seen in this case. And the surgical fact and also some factors that contribute is either there was a limited exposure of the ovary because of adhesions, or due to the compromised surgical technique we can see. The other factors could be the limited exposure can be due to adhesions or endometriosis that is causing the adhesions. There could be anatomic variations also, and there could be an intraoperative bleeding that could hamper the tissue also. So either can be also poor surgical technique, that we don't have an adequate exposure, we don't get an adequate exposure or restore the adequate anatomy.
How you will diagnose this patient?
Ma'am, for diagnosis of this patient, there should be a surgical exploration and confirmation of a possible ovarian tissue. So the candidates who are not for surgery, the clinical diagnosis we have to be made on the symptoms or examination findings, the levels of FSH and estradiol as we have gone in this patient, and laparoscopy also can help in diagnosis of this patient.
So for diagnosis, can we give some hormones to suppress the ovarian function? That can also give us the diagnosis. Can any panelist add on? Can any panelist add on? Dr. Ashima, Dr. Kavita?
For the initial workup, if a patient comes with a chronic pelvic pain after surgery, so for an initial workup, the history and maybe an initial ultrasound workup might give us a clue that there is some mass, which could be an ovarian mass, which can be confirmed with the CT or MRI. And maybe once you have a provisional diagnosis of ovarian remnant, then the surgery can be done. But before surgery, yes, hormonal treatment can be tried to see if we can suppress her ovaries, which are the cause of the chronic pelvic pain.
Because I think if first surgery was so difficult, then how to go for the second surgery? It will be more difficult, I think.
I've tried oral contraceptive pills for my patients who come with this activity. So many of them, if you give continuous for 3 months, they do respond, and this sometimes disappears. But then you have to have a differential diagnosis with peritoneal inclusions.
Yes, we are coming on that also, Dr.
And one thing also we can do that we can give her clomiphene citrate 100 milligrams for 5 to 10 days. That will increase the size of the ovarian cyst, and we can diagnose it by laparoscopy or by ultrasound, the size is increased or not. That is also one of the future.
Have you ever given, Dr. Pathak, have you ever given this clomiphene citrate?
No, I have not given, because I don't go for endometrial surgery in our hospital.
But Dr. Pathak, it looks strange now. You increase the problem of the patient for the diagnosis. So I think the COCs would be a better option.
So diagnosis as well as treatment.
Remove the remnant ovary, then it will become more prominent. because in the midst there was already adhesions, lot of adhesions, and it may be difficult to exactly locate the pinpoint site of the ovary, rimmed ovary. So it will increase the of the ovarian remnants, remnant ovary. So that will make us difficult, make it easy to operate and remove the remnants ovary.
So treatment is first is hormonal therapy to suppress the function if diagnosis is confirmed, and otherwise removal of the residual ovarian tissue, definitely surgery, and appropriate evaluation for the malignancy if mass is present. And if patient is not suitable candidate or refuses for surgery, then alternative therapy, definitely it is hormones. But from my side, hormones should be tried first. And medications are GnRH agonist, danazol, or ocipils, as Dr. Kavita has rightly said. Now, Dr. Siddharth is also here with us. Dr. Siddharth, welcome. And coming to the case 5, this is for Dr. Ashima.
Good evening, madam.
Good evening, Siddharth. Good evening. I am coming to you also for one case after this case discussion. Case 5 is 43 years old female with delivery of 2 children by cesarean section. She presented with a history of pain abdomen since 6 months. Pain was dull, aching. It was not radiating. History of amenorrhea for 5 months. No episodes of nausea and vomiting. Urinary disturbances or diarrhea was reported. Nothing was there, and there was no any medical or surgical illness. On examination, vitals was stable. Abdomen was not distended. There was no tenderness. On post-speculum examination, cervix was looking normal and healthy. Uterus was bulky, mobile. There was right-sided fullness present. On ultrasonography, mild fluid collection in the right iliac fossa was seen, along with a cyst in the right ovary, which was measuring 5 centimeters. Uterus was of normal size with no evidence of adnexal mass or calcification. Now, Dr. Ashima, this is a question for you. What is your probable diagnosis?
So the probable diagnosis, a patient who's undergone surgery, cesarean sections, and now having a chronic pelvic pain with the ultrasound finding of fluid collection around the ovarian cyst. So the diagnosis is most probably a peritoneal inclusion cyst, because there's a peritoneum which is secreting secreting some kind of a fluid which could be proteinaceous, could be sebaceous, and a normal ovary tries to absorb and clear it. But sometimes ovary gets trapped in that fluid because it cannot absorb, and that causes a formation of peritoneal inclusion cyst, which is generally seen after surgery, endometriosis, trauma, and other inflammatory conditions.
I think one patient, same we both have encountered. We have undergone here surgery for endometriosis, and later on that patient came to you with peritoneal inclusion cyst. Again, RPG student was there. She came to you later on because she was from Ludhiana. And how does the patient presents when she's having peritoneal inclusion cyst?
So again, the symptoms would be something like a chronic pelvic pain. It could be some GI symptoms like constipation, tenesmus. It could be urinary problems, the frequency. It could be just generalized anorexia. And there could be even a dyspareunia and abdominal fullness. So it could be any kind of a spectrum of pain. And then you take after taking a detailed history, you do a per abdominal examination and do a PS examination. You might find some fullness, some non-specific findings. Then you can, for the initial workups, we subject them to an ultrasound to confirm our provisional diagnosis. But then CT or on ultrasound, we see the ovary trapped in the fluid like a spider in a web, and similar findings are seen on CT as well. So that is how we conclude step by step that it's the peritoneal inclusion cyst.
They are usually found in women with a previous history of any surgery or chronic PID, and entraped ovary appears like spider in a web. That is typical finding and may be mistaken for a solid tumor of the ovary. And ultrasound diagnosis depends on seeing a normal ovary on the same side with surrounding loculated fluid conforming to the peritoneal space. Dr. Anju ma'am, you want to add something? Or any other panelists?
Yeah, I want to make a comment. I think we'll have to rule out tuberculosis infection also in such a case.
Yes.
What do you say, Dr. Ashima?
Yes, for all chronic illnesses, we must rule out tuberculosis. Very well said.
Thank you.
Properitoneal cysts are very common in laparoscopy also.
Yeah.
Yes.
You try, it's very difficult to enter first of all, and when you enter search, there is no ovarian cyst. Yes, we are running late, so we won't discuss that much, I think.
So this is the question for Dr. Siddharth. 39-year-old
Yes,
para L4 female presented with a history of recurrent urinary problem. She gets sudden intense pain with an urge to urinate, increased frequency of micturition during day and night, with passage of small amounts of urine. Pain increases as the bladder fills and improves temporarily after emptying the bladder. There is no discharge per vagina. She has regular cycles. There is an increase in the pain during menses after intake of certain foods. Perspective normal findings. PV uterus is multiparous, fornix is clear. Slight retropubic tenderness on bimanual examination. No cervical motion tenderness. Ultrasound is showing echoes in the bladder lumen, uterus and admix are normal. Now this question is to Dr. Siddharth. Dr. Siddharth is urologist at our center, SGRD Medical College, and he is assistant professor in urology department. Dr. Siddharth, what is your diagnosis?
Can you show me previous slide once again?
Okay.
Can you show me previous slide once again?
Previous one.
This one.
This one. This one.
This one only. That's all. That was next slide.
Okay. This is a question for you.
Next slide.
Okay. What is your diagnosis?
Madam, in this patient shows that patient must be having some bladder, small bladder, or maybe patient have interstitial cystitis or infection, chronic UTI, or patient may have something like a patient has a bladder with overactive tendency because of some previous surgery. So in such patients, as you said, patient cannot able to collect much amount of urine. That means small amount of urine goes to bladder and it tries to push it out. So in such patients, we first rule out any chronic urinary tract infections.
Urine incomplete is normal
Any
and urine culture
previous
sensitivity is also
surgical
normal.
problem like a surgical injury, like an history of a cesarean. Hello? Hello?
We can hear you, sir. We can hear you.
We can hear you.
Hello?
We can hear you, sir.
You are audible. You are
Hello.
audible.
Maybe we are not audible.
You are audible. आवाज आ रही है आपकी?
Hello?
Hello?
Am I audible?
Yes, Dr. Siddharth, you are audible.
Am I audible?
Yes.
Yes.
Anjuman,
I'm saying he is audible. You are audible.
But he can't hear us.
Anjuman, you can take this question. IBS, if he is not.
Yeah, it's a very, very common problem which is missed
Hello.
very often, because you have given a very clear indication that some of the food increases the problem. You know, there are bladder irritants like preservatives and some kind of, citrus juices and aerated drinks and spices and, this like orange juice and these things. They are preservatives. These are the things which are, increase the patient's problem, because interstitial cystitis is a problem. I had one patient where, she suffered and ultimately it was found to be having this problem of interstitial cystitis because of, when we took a great history, caffeine, tea, lot of things, which irritate the bladder. There are, for different patients, there are different kind of food items. So you have given a very beautifully explained everything, that the urine routine is normal. But in these cases, sometimes you have to resort to doing a pelvic flowmetry to rule out, these are the cases which can be confused with overactive bladder syndrome. So you have to differentiate between overactive bladder syndrome with chronic recurrent infection and then this painful bladder syndrome. So, but your history is very suggestive that some of the food item increases. So these patients are always advised to, stop some things for a while. Supposing she is having problem with tea, coffee, so she has to stop it for some time
Hello.
and feel how she feels, and then further on, like some kind of spices or some kind of citrus food, like some people have with lemon juice or tomato, something like that. So there are different foods which every patient has a different kind of response to different kind of foods. So that is one thing. And then we have to, these patients also very well respond to the peripheral nerve stimulation, either stims or PTINS. That is also very good because that really helps them. And of course, painkillers around the clock, and anti-anxiety drugs, pelvic floor exercises. And sometimes you have to look for the trigger points. There was a patient who had this permanent contraction of piriform muscles, which used to give her this problem. So, giving relaxation massage to that pelvic piriformic muscle really helped. So these are the patients who, you need to diagnose where the problem is, how it is arising, and how to catch hold of that problem and then treat it. So first is lifestyle management, diet management, fluid management, because sometimes people say take plenty of fluids, that increases the problem further. So, and then later on, we have to go to the drug and therapy and other things.
Thank you, ma'am, for giving your inputs. Dr. Siddharth, are you there now? He was speaking in between. Actually, his
I think he had some problem with his bandwidth. He couldn't listen to us.
So exact cause of interstitial cystitis is not clear. Unlike other types of cystitis, there is no obvious infection in the bladder, and antibiotics do not help. So treatment, madam has rightly said, analgesics, easy antidepressants, and tolterodine, solifenacin, or mirabegrone nowadays, they help to relax the bladder muscles. And intravesical medications also can be used, that is lignocaine, hyaluronic acid.
Botox have also been shown to give
can also be used.
Yeah.
Shobna ma'am, can we stop this now and we can go to the next, or shall we continue?
Dr. Shobna, you're muted. Dr. Shobna, you're muted.
Sorry. I think we should stop it now. It's 1 hour since the panel started. And after Ragini's talk is over, we can continue if there are audiences. But this link, I can't make out if there are audiences in the audience. I can clearly tell us if there is anybody in the audience. They're also not there. Okay, we will finish Ragini's talk and then we will continue with this. That's.
Jabulina is there, but she is
You must have just put it on and gone somewhere. It's okay. I think it's only fair because we have 1 hour for the panel. That 1 hour is now over. What do you think?
Yes, ma'am. Yes, ma'am.
Yeah. Let Ragini finish, then we can come back.
Now, should I stop sharing? Debolina, are you there?
She's not there.
Debolina?
Dr. Agni doesn't require any introduction. I could give her her introduction.
Now we come to the next session, that is recurrent UTI. And the speaker for the session is Dr. Ragini Agrawal ma'am, who is in my rag, and I love her from my core of my heart. And she is the actual founder of Amritsar Menopause Society. Over to you, Ragini ma'am. And chairperson for this session is Dr. Siddharth. He is assistant professor in urology department of SGRD Medical College. Whenever we are in trouble during cesarean or even during delivery, he comes as fast as he can come. Welcome, Dr. Siddharth. And over to you, Ragini ma'am, for your presentation.
Thank you, Sangeeta. Thank you so much. And thank you, Dr. Shobna and Dr. Anju, for giving me this platform again to speak. And I will like to do one webinar
Dr. Agni
also.
I want to give your 1 minute introduction. Dr. Agni, I want to give you 1 minute introduction. You have been a vice president of Foxy, and you are, a person for education.
I am the national convener of the this project of IMS.
Yes. So you have got many laurels to yourself. So you're welcome to this program. And
Thank you
we are
so
very
much.
happy
Thank you
that you
so
are
much.
there.
So my topic is, let me share my slide first. And literally, it is a mutual admiration club, Sangeeta. We really fell in love with her first sight.
Thank you, ma'am. Thank you. Thank you.
Are you people are able to see me? See it? No.
No.
Ragini Agarwal has started screen sharing. That's all we can see.
पता नहीं इसे आ रहा है मैं बैक में
The
भी
screen, ma'am, you click share screen.
but I am able to see you all in my screen also.
But you share screen,
Maybe
then
you put the screen share screen button on your PPT first.
नहीं वो तो सब मेरा ऑन है मेरे ख्याल से मैं पीछे जा. You are able to listen me? No.
Yeah.
No.
listen.
I think it is hanged little bit. Can I out and then come again? I think it is hanged. Just a minute. तब से तो चल रहा था. Just give me 1 minute. It is, I think, you are able to listen me?
We can hear you.
Okay. So I think this is hanged. I'm not even able to leave it. What you do? If you are able to listen me, Sangeeta, then you can make me out. You share. Devina,
Yes,
you
ma'am.
can make me out.
Maybe you can talk without the slides. You can just put it on in your system and read it out or talk to us without the slides.
Devina is there?
Yes, ma'am, I am here.
Devina, आप मेरे को
Sorry, ma'am.
Ragini ma'am.
हाँ.
Can I take it on my desktop and then can I share? Give
Yes,
me 1
yes,
minute.
yes.
Give me 1 minute.
You stop. Please stop my sharing because
I will share your screen. I will share.
Yeah.
Give me 1 minute. Let me
Yeah.
download this. Okay.
I can speak, but it will be okay. Made this slide with a
No problem.
So I will start. I will. Meantime, they will do that. I have turned. So I have focused on men. Why and current UTI is special that who is young.
I'm starting sharing screen.
Okay.
Wait, just 1 minute. Okay, now, is it visible to everybody? Is my screen visible?
Yes, your screen is visible.
Ragini ma'am, you can continue now. I will share your screen.
No, मेरा ये है इसमें से ये मेरा लगता है. I'll just do this thing. और आज तक कभी हैंग. अमृतसर
visible?
नहीं मुझे कुछ नहीं दिख रहा है. मेरा लगता है हैंग कर गया है. मैं इसको खोल रही हूँ.
मैम recurrent UTI and menopause आपकी स्लाइड मेरे सामने है. You read your from your side. I will share the screen.
हाँ, I'm going out.
Join again. Out and join again.
Hello.
Hello.
Yeah. So, I am not able to see your screen.
Ragini ma'am, you are not audible.
I'm not audible also.
Now you are audible clearly.
Hello.
Hello.
I'm audible.
Yes, Ragini ma'am, you are audible.
Yeah. So, very good evening to all of you. My topic is recurrent UTI and menopause. And with the blessing of Mahakal and the gratitude to everyone for have taken the photographs or article, I will continue with the, please move the slide to the, before this slide. Recurrent UTI के ऊपर ले जाइएगा. हाँ. Before, yeah. So whenever I talk about any woman, it's great about the woman. After this, yes. Yeah, the most authentic thing about us is our capacity to create, to overcome, to endure, to transform, to love, and to be greater than our suffering. This is a woman. So first is next slide. Next. Yes. So UTI are one of the most common infection and up to 50% of men in their lifetime, with almost half of these women experiencing a recurrence in 6 to 12 months. What we say, once UTI, it is very difficult that woman is not going to have a UTI again. The females are more likely to get UTI than the male. We all know that most of the 60% of female in comparison to the 12% of the male, because of that anatomical reason of the urethra is very, very near to the anus. So the bacteria have less distance to travel to reach the bladder. Next slide. Menopause predisposes women to recurrent UTI, as normally lower levels of the estrogen lead to difficulty. When you see this diagram, when there's a estrogen present, there's a lactobacilli dominant environment. There's a glycogen-rich lining, and there the pH is decreased. Whenever the estrogen is reduced, there's a lining is broken, and there's a less glycogen for the lactobacilli, and the pH will be increased. It will be acidic pH. So more of the infection. Next slide. So as if puberty and childbirth were not enough, vagina and the vulval area are in for changes as women get older, especially after the menopause. So how the menopause and the UTI are linked? The estrogen deficiency plays an important role in the development of the bacteria. Several studies have been conducted showing the efficacy of the estrogen in the prevention of the UTI. So coming to the demography, next slide, please. Three groups of the women recurrent UTI should be distinguished when we talk about the women. Asymptomatic women, younger menopause women up to 70 years, all the women after 70 years. So bacteria occurs more often in functionally impaired women than in those who are not impaired. This is very important to remember when we are talking about the menopausal women, whether we are talking about active young menopausal women or talking about the impaired, invalid menopausal women 70 plus, which is this year we are taking in a big way under the leadership of Dr. Shobna Mohandas. Persistent bacteria is seen more often in nursing home residents, and the transient bacteria is seen more often in young, healthy postmenopausal women. Next slide. The majority of the elderly women with bacteria are asymptomatic and should not be treated with antibiotics. So this is a very, very important thing. When an elderly woman coming to us with a symptom of the UTI and we write an antibiotic, it is not good at all. And many times it is a sterile, but the patient is complaining of a dysuria frequency without thinking they get an antibiotic, and we predisposes there more of the infection. So in young to middle-aged women, the prevalence of the UTI is less than 5% and rising considerably with the advanced age. Epidemiological studies have shown that 15 to 20% of 65 to 70-year-old women have bacteria, compared with the 20% to 50% of the women more than 80 years old. Next slide. And not only this, it is a very, very important thing in the elderly women. Many a time this bacteria will lead to a urinary septicemia and lots of problem. Foxman et al. Conducted a case control study investigating the role of health behavior and sexual and medical history in UTI risk among the otherwise healthy women aged 40 to 65 years. What they have showed that the sexual activity was not associated with acquiring UTI in this age group, whereas a history of the UTI during the past year, urine loss, antibiotic use during the previous 2 weeks, and the exposure to cold during the previous 2 weeks were positively associated with the UTI. In addition, drinking cranberry juice and the taking vitamin C are moderately productive. Next slide. So when we see the major factors which are predisposing the adult woman to UTI as related to age, up to 50, sexual intercourse, diaphragm, spermicide, antimicrobials, prior UTI, maternal history of the UTI, childhood history of UTI, these are the predisposing factor. But when we talk about the 50 to 70, the lack of the estrogen come on the top, then the urogenital surgery, incontinence, cystocele, post-void residual urine, and prior UTI. And when we talk about the invalid or institutionalized impaired women more than 70, the catheterization, incontinence, and the urogenital surgery and the atrophy tops the list. Next slide, please. So recurrent UTI and the menopause may be linked by the estrogen level. This is an important factor in these women, the potential role that estrogen deficiency plays in the development of the bacteria. And they frequently present with the genitourinary symptoms. Half have genitourinary disorder and 29% have incontinence. So postmenopause is characterized by a significant reduction in the ovary estrogen, which we know, and which lead to a vaginal atrophy also. If we remember our embryology, this urogenital epithelium is developed from one place. So when the vaginal epithelium become atrophied, it causes of the also. Vaginal dryness, itching, dyspareunia, urinary incontinence, what we called as a GSM today, or genitourinary syndrome of the menopause, which can imitate like a UTI. Next slide. So we all know what are the changes in the vagina and vulva, which lead to a tissue of the vulva and lining of the vagina to become thinner, drier, and less elastic or flexible. So think of the same thing is happening to the urinary epithelium also. Now this shifting level of the hormones, especially estrogen during the menopause, transition produce changes in a woman's body. Both the vagina and the external image genitalia, vulva, along the urinary epithelium is also affected. Next slide. Vulvovaginal atrophy, we all know that the less estrogen may cause the tissues of the vulva and the lining of the vagina become drier, secretion are less, increase in the vaginal pH, which leads to the more of the infection, and that infection from the vagina, because of the short urethra, can easily invade the bladder. Next slide, please. So many women struggle in silence, not even knowing they have treatment for it. Next slide. So estrogen stimulates the proliferation of the lactobacillus in the vaginal epithelium, reduces the pH, and avoids vaginal colonization of the Enterobacteriaceae, which are the main pathogens of the urinary tract. So this all three holes is very, very close in the woman. When we talk about the urethra, when we talk about the vaginal orifice, and when we talk about the anus, and so we have to think of invading of the pathogens from the anus, from the gut to the urethra also. Next slide, please. So decreased estrogen leads to the decrease in the vaginal lactobacilli, increases in the vaginal pH, and the colonization of the vaginal with the Enterobacteriaceae from the rectum. Next slide. In addition, the absence of the estrogen decreases the volume of the vaginal muscle. That is a very, very important thing, resulting in the slackness of the ligament holding the uterus, pelvic floor, and the bladder, resulting in the development of the prolapse of the internal genitalia. And when there's a cystocele, there's a urine which is there, and it can lead to the infection. Next slide. The previous randomized double-blind placebo-controlled study demonstrated that the vaginal estradiol treatment had a dramatic effect on the recurrent UTI in the postmenopausal woman. The results showed that the incidence of the UTI in the women who received the vaginal estradiol was reduced to 0.5 episode per year compared with the 5.9 episode per year. In addition, after 1 month of the treatment, lactobacillus appeared in 60% of the estrogen-treated group, but none in the placebo group. Next slide, please. So another study using an estradiol vaginal ring presented that the women in the estradiol group have significant reduction in the frequency of the urogenital symptoms such as vaginal dryness, dyspareunia, urge, and stress incontinence after 36 weeks of the study. And 45% of the women receiving estradiol were still free of the UTI, in contrast with only 20% of the women treated with the placebo. Next slide, please. So how to manage? The question arises, how to manage? Although there is no clear-cut solution to the problem of UTI in the postmenopausal women, various strategies can be employed that have found success. Next slide, please. And foremost is the asymptomatic bacteria in the postmenopausal woman. It is not recommended to treat asymptomatic bacteria as it may paradoxically increase the risk of the symptomatic UTI. So the goal is to treat as necessary, but to avoid over-treatment in the postmenopausal woman. Next slide, please. UTI in postmenopausal woman may occur with the typical symptoms like urgency, frequency, dysuria, or fever. In some patients who are impaired meditation, the diagnosis can be less obvious and is often implicated as a causative factor in temporarily decreased cognition. In patients with history of the lower urinary tract, symptom may be exacerbated by UTI, but in the absence of the typical UTI symptom, it is often difficult to determine whether an uptick in lungs is really due to UTI or is a simply symptomatic fluctuation superimposed on the asymptomatic bacteria. Next slide. So what is important? What we talk about in the panel, what we talk about in the Dr. Mohandas lecture is a detailed history, which we many a time in a busy OPD is not going to take. So the appropriate management of the patient presenting with the recurrent UTI starts with an appropriate evaluation. We have to talk about the symptoms, severity, frequency, microbiology, comorbidities, prior evaluation treatments, and what is the response to it. Contributing condition may be identified on the physical examination, bimanual and vaginal examination. It is very, very important to examine this patient, not only just to write the treatment. A key step is to elicit the symptoms associated with a reported UTI episode and match them with the laboratory finding. Many times the patient urinary symptoms are not due to the bacterial infection. This is very important to remember in these women. And this distinction is critical to make since prevalence of the both asymptomatic bacteria and the lungs is high in the elderly women, and bacteria may be inappropriately inflicted as the cause of the patient trouble, where it might be because of something else. And what something else, along with the DSM, may be the primary widening dysfunction because of the age, because of the comorbidities like the long-standing diabetes. And this diagnosis of the recurrent UTI may result from the follow-up culture obtained by a physician after antibiotic treatment that really only shows the recolonization of the asymptomatic bacteria. Next slide. So if history is obtained that is consistent with the recurrent bacterial UTI, then you have to go and see the hidden needs like a stone or anything else. In patient with a recurrent UTI with a variety of the organism and no history of the infection, neither cystoscopy nor upper tract imaging is necessary. Then you move to the management like treatment of the contributing factors, prevention, and the antibiotic treatment. Next slide, please. What is the treatment of the contributing factor? Always remember vaginal atrophy, specifically in an elderly postmenopausal man, and pathogenesis of this recurrent uteri may be alteration in the bacterial flora, changes in the vaginal pH, breakdown of the natural mucosal layer, preventing the cellular infection in the uroepithelium. So, mechanism of the local estrogen replacement is stimulates blood flow, increase pH, and the aim to restore mucosal barriers. So, it was found in a Cochrane review that vaginal estrogen reduced the recurrence of the UTI compared to placebo. No such benefit was found with oral estrogen, and risk for the local therapy are very, very low. With the most common side effect is the local irritation. We should always give this recurrent UTI patient a vaginal estrogen. So when we come to the role of the probiotics, although it is controversial, but some paper are coming up, and we are also using lots of the discussion on the gut microbiota and the probiotics. The purported mechanism of the action of the probiotics is to establish vaginal colonization that act as barrier to infection, prevent recolonization of the vagina, or modulate host defense. Next slide, please. The most evidence is for use the endovaginal substitute of the lactobacillus. In a recent RCT, use of such an approach had a relative risk of 0.50 in young women. Given the low risk benefit profile of intravaginal substitute taken on a weekly basis after treatment of the acute UTI, this tends to be an attractive option for patients interested in the non-antibiotic based approach. Next slide, please. So cranberry extracts or cocktails taken on a daily basis are believed to reduce the risk of the recurrent UTIs, and there are expensive, well-tolerated dietary supplement that has evidence supporting its use. So if you are really going to give an antibiotic, how you go for the antibiotic strategy? Antibiotic prophylaxis is a highly effective way to reduce the incidence of recurrent UTI. As in, most commonly used are trimethoprim, sulfamethoxazole, or only trimethoprim if a person is allergic to the sulfur drugs, ciprofloxacin, cenfalexin, and the nitrofurantoin. Next slide, please. So when we talk about the standard dosage regime, use dose nightly administration to reduce effective antibiotic concentration in the urine without using resistance in the gut flora. It is critical since the gut is the source of the potential uropathogens, and the higher dose will compromise the effectiveness of the prophylactic regime. Next slide. Recommended dose for the trimethoprim and the sulfamethoxazole is 400 of the 80 milligram. Ciprofloxacin is 250 milligrams. Cenfalexin is 250 milligram. Mind it is only prophylactic dose for a nightly given low doses, and trimethoprim only as a single agent also. Nitrofurantoin is a very useful prophylactic agent, but we have to be little bit discouraged you are using in the elderly because of the serious, including the pulmonary fibrosis. Next slide, please. So it should be therefore based on a careful consideration, and in postmenopausal women whose UTI are clearly related to sexual activity, postcoital prophylaxis can be prescribed. Next slide, please. So dose the stem is next slide. Next slide. Next.
Next is not coming, ma'am.
Huh?
Okay, done.
So there's something called self-start therapy. This often elevates patient, but we have to emphasize this only recommend when you are a highly reliable patient who has been thoroughly evaluated and appropriate consent. Next slide, please. So this is GSM. When we talk about this recurrent UTI, we have to keep in our mind always this GSM, the genital sexual symptoms go hand. Next slide, please. Next. Whenever we are talking, we are talking about the changes in the vagina and vulva, and there's an infection connection. Can become thinner and more vulnerable to the sexual transmitted disease and the bacterial vaginosis, specifically in these women. And management of GSM is also with a history, potential risk, use of the exogenous administered estrogen therapy, and the patient lifestyle. Next slide, please. We should all remember the local therapy of the estrogen is the gold standard, and we have other options also. Next slide. Selective estrogen receptor modulator, combination of the blown DHEA when we are talking about the recurrent UTI along the GSM. Next slide. So pelvic floor physiotherapy, what I have found is a wonderful whenever a patient with the incontinence comes to me, and the new thing is the energy device. Really using in my patient the fraction microvibrating, and this when we talk the GSM patient recurrent UTI. Next slide, please. So this is being, it causes the collagen traction and the neurogenesis, vascularization, and the growth filtration, causes the activation of the heat protein and tissue growth factor. Please. So laser therapy is also you can use post-cancer treated patient for the GSM. Next slide. This carbon dioxide laser which I am using is in a GSM. It is a real wonder thing.
It is more than 25 minutes. I hope you can finish it quickly so that we can have.
Next slide, please. Next slide. Next slide. So it is a minimal, virtually painless procedure and gently, very precise. Has a absorption and manages the damage and the collagen remodeling. 3 phases with the early effect to the next slide. Treatment protocol is very simple. It's a procedure like in a break, 3 sessions with a 1 month interval. Next slide. To conclude, recurrent UTI in the postmenopausal woman is a common problem that can be effectively addressed by a stepwise approach that produces history and elaborate evidence for the recurrent symptomatic UTI, rule out the bacterial persistent relapsing infections, then merit the diagnostic evaluation. And this entity should be distinguished from the asymptomatic bacteria, which should be miscontrolled without antibiotics. Next slide. So thank you so much for your hearing, and I'm extremely sorry. It really had me.
No.
That
so it's okay.
part
Dr.
of webinars.
Ragini, you are really good. And amazingly, you took the topic, such a huge topic. And I'm sorry, I will have to leave because I have an emergency case in the hospital. Bye-bye. Thank you, Dr. Shobna. Thank you, each and everyone, especially the organizer, beautiful Sangeeta. Thank you, everybody.
Thank you, ma'am. Thank you, Ragini ma'am, for such a wonderful lecture. And recurrent UTI, we daily and day-to-day practice, people are coming and they are having UTI, and we are giving NFT. If they are not responding to the NFT, then we are coming to the ciprofloxacin and so on. Now I want to take feedback from Dr. Siddharth. What's your opinion regarding antibiotics in recurrent UTI? Dr. Siddharth? Unmute yourself. You're muted. You're muted.
Good evening, everyone. Madam has explained almost everything. As she said, we should, in recurrent UTI, we should give low dose antibiotics, especially sulfur
sulfamethoxazole and trimethoprim, nitrofurantoin, as he said, and the ciprofloxacin, any fluoroquinolone should be given for long-term basis. And second strategy is self-start therapy. Whenever patient feels patient is having a again infection, and she can undergo a culture sensitivity, and she can start that antibiotics for 3 to 5 days, full dose. Or third thing is when it is sometimes like after a sexual intercourse, sometimes patient has, then patient can after a post-coital can take one single dose. So we usually make these three strategies for treatment of recurrent infections, as she said.
Thank you very much, Dr. Siddharth, for your information regarding recurrent UTI. And Shobna ma'am, do you want to add something?
No, we had a joke about this post-coital UTI in Calicut, and one male doctor said, "Kya bolte? Raat ko 3 baar goli khane ka?" And I was saying that, sir, you're talking of post-menopausal women, and I had to remind him, so whether they will be taking post-coital. So it's a standing joke, so we don't know how often they'll have to take it in post.
Single dose they take.
Yeah, but he says 3 times means 3 goli, no? So that's what he says. I don't know how far it is true, but yeah, that's a questionable thing.
Yes. Thank you so much, ma'am. Now I would like to hand over to Dr. Preeti Dev.
Do you have any audience and do you want to continue our panel, or shall we call it today?
Ma'am, we have not received any question from the delegates in yet.
Yeah, but their panel was not completed. Is there any delegate left in the audience? Because we have different links, we do not know, or we will call it a day. Debolina?
Yes, ma'am, there are some of the delegates. And besides, ma'am, we have already crossed the time also.
Okay.
So that's up to you if you could conclude.
Okay. CV of Dr. Preeti, please.
Sure, ma'am, I'm sure.
Dr. Preeti Dev is Secretary, Amritsar Menopause Society, and she's life member of IFS, ISDCP, and she's working at Dev Hospital, and she's doing wonderful job in a hospital, and she's doing laparoscopies, hysteroscopies, and all the treatment of the high-risk pregnancies. I now hand over mic to the Preeti for vote of thanks.
Thank you, Dr. Sangeeta. First of all, I would like to thank Ma'am Shobna and Ma'am Anju for being the guiding force behind this webinar. Next, I would like to extend my thanks to Ma'am Ambuja and Ma'am Sudha for being the guest of honor, and Dr. Sonia Malik and Dr. Siddharth for being the chairpersons of our this knowledge-filled evening. I would like to extend my thanks to all our panelists for sparing their time and joining with us. And last and not the least, I would like to thank all our viewers for joining us, and Dr. Sangeeta for organizing such a wonderful and knowledge-filled evening. Thank you all. Thanks a lot.
Thank you. Thanks a lot. Thank you.
I would like to thank Shobna ma'am and Ragini ma'am. Both are the wonderful persons and really hardworking and talented. And Shobna ma'am is the real force behind, and Ragini ma'am is always there to help us. Thank you so much.
Thank you, Sangeeta. You have organized so many panelists, and we had all vague things like pelvic, congestion, nothing common in pelvic pain, she said. Everything was out of the box, and it was really nice. I think. What do you think, Ragini? She's taken efforts to get all the vague things down.
Thank you very much, ma'am. Thank you.
It's very nice.
Thank you so much. Also,
thank you so much. Thank you, Clearnic, for being with us for all our endeavors.
Thank you, ma'am.
Thank you so much for the hard work.
Thank you to all the panelists, Dr. Siddharth, and good night to everyone. Thank you so much.
Thank you. Thanks a lot.
Yeah, and thanks to all the delegates. We are closing here. Good night, all.